Controversies and concerns. Negative consequences. To decrease suffering, one consequence may be that, let's say that somebody has developed depression because they're living in a relationship that is horrible, where there's no intimacy, or they're constantly being belittled or used or hurt, taken advantage of, and so forth. They develop depression. Some people have argued, well, but you know, if we treat with medicines, it alleviates the depression. Maybe, therefore, we can, you know, the person will stay in basically in a relationship that's toxic. Is that a good idea? I mean, I'm not going to say I have any answers to these questions, but I think they're legitimate issues. Distance people from their humanity. Now, let me explain this to you. It's interesting to think about. This hasn't been written about very much. I've rarely heard about it. I think there's something to this, and that is that the issue is, what is it that brings people closer to God? What is it that drives people to get clear about what matters to them in their life? Those kinds of existential and spiritual issues. A lot of times it's suffering. Not to say that suffering, you know, we ought to, you know, embrace suffering, you know, for its own sake. But the point is that these are parts of the human condition, and they cause pain, but might they also be essential life experiences that potentially transform people? And so what if as a culture, we rush in and try to provide medical treatment to buffer people from having to experience that? Now, again, I don't know the answer, but it's a question mark. Let me tell you something. Let me give you an example of this, okay? It could seal things over for some people, all right? I also had this woman who was 83 years old, and she came in to see me, and she's a devout Christian, and one of the worst things about her major depression was, she said, honest to God, John, ever since I've been a teenager, church has been at the center of my life. I would go there and I would feel swept away. I believe in God, and since I've been depressed, I go there and it's an empty experience. I feel nothing. The hymns that would always move me to tears do nothing for me. Okay, she went on and on, but she's talking about anhedonia. Okay, she's emotionally dead because of the depression. She got treated with psychotherapy, but also antidepressants. And one day she came in, and this gives me goosebumps. This was years ago, but she came in and she said, and I don't remember what the hymn was, but maybe it was Amazing Grace or something like that. And she came in, this was like maybe 8 weeks after she started antidepressants. She was getting better. And she said, guess what? They played Amazing Grace in church, and I started to weep. So, you know, this is not a black or white either or kind of thing, too, because the impact of the deadening of aliveness you get with mood disorders also can distance people from their humanity, right? Okay, help people live up to cultural expectations. Carl Jung says neurosis is always a substitute for legitimate suffering. And I think he's talking here about the psychodynamic notion, neurosis being gritting your teeth or being over-defended. And a lot of people come in, you know, with depressive symptoms or anxiety attacks or tension headaches or what have you, and they want relief, but it could be, in at least many instances, what's going on is they've had a very significant and painful life experience, and they are psychologically gritting their teeth and trying to avoid the pain. And a drug may reduce the suffering, but does it get to the heart of the issue? Now, I think this has really become a real concern, an unanswered question about whether this is right or wrong, in the use of antidepressants to treat normal bereavement. 25% of people who have a significant loss of a loved one from death in the first year will develop major depression. 75% of people, it's going to be maybe one of the worst things that happen in their entire life, but they won't become clinically depressed, but they will walk through grief and they will mourn. And there are studies now that show that you can reduce the suffering a normal bereavement with antidepressants. The big question is that the right thing to do? Okay. I mean, these are questions that we have to balance, in working with our clients. Because I'm going to show you some data later that shows all antidepressants except Wellbutrin, but all of them that affect serotonin eventually blunt affect to some degree. Do you want to do that? I will say that pronounced emotional blunting probably happens in less than 20% of people that are chronically on antidepressants. For most people, they get it. It's subtle, but it's there. Okay, and this is really one of those that there's no formula here. This is a clinical judgment call. But we may be having a combination of a person's characterological stance, where they are over-defended, intellectualizing or what have you. You add on top of that a drug that blunts emotion, and it may be your judgment that this is not a wise thing to do. But again, like the woman who had depression, when I've seen people who have major depression following the loss of a loved one, and they've got the real McCoy. I mean, they got severe sleep disturbance and low energy and anhedonia. What I'll tell them is I'll say, here are the symptoms the antidepressant hopefully will address. And I'll talk about sleep, and I'll talk about energy, and I'll talk about appetite and stuff like that, okay? And I say, here are the things that won't address, and that is, this has broken your heart. I think, and people have written about this, I think a part of the depression is not just that you're suffering more, but actually depression paralyzes people emotionally and cognitively and shuts them down. And a lot of the experts on bereavement say you got to treat the depression either with psychotherapy and or medication in order to free people up from the depression so that they can continue the process of mourning. And so, being honest and saying, I cannot be a part of, an idea where we use medicines to put a lid on this. I just don't think it's a good long-term solution. But for some people, treating with medications makes a lot of sense. So, again, it's a very complicated kind of issue. It's got to come out, of course, but that really doesn't address the deeper problem. Okay. Well, I thought it was funny. Anyway. Okay. Well, as psychotherapists, I'm going to preach a little bit here, okay? So pull out your hymnals. Here we're going to sing a little psychopharmacology song. As psychotherapists, I think that in various ways, most of us endorse the notion about the importance of personal growth, facing your demons, working through things. I mean, I do. I think that's the pathway for healing for many people. But guess what? In the real world, there are going to be some people that are going to say, I don't want any of that shrink bullshit. Or I'm a private person. I don't want to spill my guts in front of you, or something like that. And so what's our stance going to be on that? Is maybe help them come to terms with that, maybe see if that's just initial resistance, but beneath there they can open up to psychotherapy. But for some people, it's who they are, and are we going to sit in judgment and say, well, you don't have the right stuff for therapy? I don't think so. I think part of this, you look at things like intellectual level, the amount of psychological mindedness, the capacity for looking, for introspecting, the willingness to go there, okay, the degree of suffering that they have, and say, I need to be flexible enough here that I can provide what I think for this person is going to help them get to a place where they're not suffering so much. And this big concern, I heard this early on when I got out of graduate school. Oh, if you use medications, though, it'll block all the feelings and you won't get anywhere. And I'm going to just tell you, and this is not research, but this is 30 years of seeing people. You know what? Most of the time, people come in like with panic disorder or major depression, and or severe PTSD. And the choice is, let's dive in here and let's get people stabilized and get them on medication. Rather than it closing the door on emotions, it puts out the big fire, the horrible symptoms, But then when things die down, most of the time people start talking, say, oh, thank God that's not as bad. Now, let's talk about the stuff that's going on in my life. You know, this either-or thing oftentimes isn't the case. So, again, this is another compelling reason for psychotherapists being involved either directly or collaboratively with medication treatment, because they're in the best position to try to really figure out, where do we go with this? Okay. Counter-arguments. I've actually already addressed some of these. When people get crippled by depression, mobilize adaptive behavior, maintain interpersonal contact, what's extremely clear from the behavioral treatments with depression is that when people begin to get depressed, they withdraw almost across the board. And getting shut off from the experiences in life that give life meaning throws gas in the fire, and depression gets worse. Sometimes using antidepressants to mobilize somebody, to kind of get them re-engaged with their life, can be helpful in and of itself. And then there's the whole issue of what Peter Kramer refers to as cosmetic psychopharmacology. And his book, Listening to Prozac, I could recommend very highly. Even though it came out maybe 14 years ago, it's still very relevant, because it's mainly about raising social and ethical issues regarding drug use. Okay? And one of his questions is, okay, it's one thing to say, here's a person who has lost 30 pounds, they're not eating, they're bedridden, they're thinking about killing themselves, and use a drug with that, versus someone who's a little bit moody, or somebody that has mild social anxiety, or somebody who's kind of non-assertive. And what's happened, as we all know, is that these drugs are not just being used for major mental illness, but they're being used for a lot of different things. And one thing about the SSRIs is that oftentimes people who've been real passive on these drugs find that they're more assertive. And guess what? Sometimes they like that. What Kramer says is, this is really interesting. We get somebody who, like for 32 years, has been kind of, sort of shy and passive and non-assertive, and he or she comes in and put them on Prozac or some other SSRI, and 8 weeks later, they say, wow, I feel different. You know what? I'm standing up to my husband, or I'm speaking out more at work. I found my voice. I'm not so inhibited about expressing my opinions. And what Kramer says he thinks is really interesting is a lot of these people that are singing the praises of this are saying, I feel like I've gotten in touch with the real me. And his question is, now wait just a minute. For 34 years, the real you has been shy. But you take some chemicals and it transforms. So how do you define the self? And is it okay, to try to polish up your personality, with drugs? Again, I'm not here to tell you the answer to that. I don't know. Okay, and we're getting close to the end of the general thing here. Long-term treatments. There are classes of drugs, classes of disorders that require very long-term treatment. Top of the list is bipolar disorder. Okay. Often schizophrenia, sometimes OCD, sometimes panic disorder. It all depends on, with these other disorders, whether a person is willing to go into psychotherapy or not. A legitimate question that gets raised a lot. Hang on just a minute. You hear this from adult patients. You hear it from parents who are considering medical treatment for their kids. Well, gosh, you're telling me, or I read or heard, you have to stay on these medicines for the rest of your life. But I mean, what's going to happen? I mean, what are the long-term consequences of staying on, on lithium for the rest of your life? And you know what? A lot of times people say, in response to this, is they address the short-term side effect issues that are well known. 35% of people that are on lithium eventually will develop some hypothyroid, but then we just replace that with thyroid hormone, and it's okay. And you can gain weight, but usually after about a year and a half that sort of stabilizes. Yeah, but the question is, yeah, but how about taking it for 25 years? You know, I'm 25 years old. I had my first manic episode. You say I have to take this the rest of my life. Well, what's that all about? Now, there are people that have taken lithium for 40 years. It's been around long enough. There are people who have taken some antipsychotics for 40 years. There's nobody that's taken Celexa for 40 years, right? It's hadn't been out that long. So clinicians have some sense about this, but there's no good research. In fact, the longest follow-up study on side effects with lithium, and I'm not making this up, is 18 months. Okay, so I think what we have to do always is be honest about this. And that is to say, a fair amount is known about side effects that you're likely to encounter in the first months or few years of treatment. There's not a lot known about the long-term consequences. And your question is legitimate, and I'm with you 100%. And if I had the answers, I'd tell you. But also a part of the response is to say, and this is not so much just to sell the drug, but it's just in the spirit of honesty, is to say, but I got to tell you something. We have to also look at the risks associated with failure to treat. With bipolar disorder, 20% of people commit suicide. Unipolar depression, 9%. I mean, I'm just giving you a couple of examples. If you have chronic or recurrent depression, your odds of dying prematurely from a heart attack are twice that the normal population. The risk of osteoporosis is twice that if you have chronic depression. I mean, you can, depending on the disorder, you can talk about potential consequences of failure to treat. But I think that practitioners need to be straightforward about the lack of knowledge about really long-term consequences. Yes, ma'am?
So when you say 20% of people with bipolar commit suicide, is that medicated, unmedicated, or everybody?
Okay, this is a very good question. She's asked, and I'm glad you asked it now because it's going to come up later. If you look at a lot of these studies, in order to determine rates of suicide, you have to determine what? That the person actually has bipolar. Now, sometimes that's done in epidemiological surveys for people, they go door to door, okay, and they make a diagnosis based on detailed interviews, and then they do follow-ups, okay. Some of these people don't get treatment. But most of the studies that show these very high rates of suicide, like with bipolar and unipolar, they are with people who have been diagnosed, they're in treatment, but they're not responding. And with bipolar disorder, I bet you can guess what the main reason they have breakthrough episodes and commit suicide. Poor compliance. It's estimated that 90% of people that are on bipolar medications will, at least for the first 3 episodes, stop their medications or take it at doses that are way too low. Beyond that, some people finally get it, oh my God, I guess I really do have to take this drug. Okay? So it's a sad state of affairs, but a lot of that negative data, comes from studies where there are people that are in treatment but they're not getting well. Okay? Partial treatment or poor outcomes. Well, we have a diagnosis. It's a metaphor. Okay. I thought it was funny. Okay. Okay. Let's see here. Let's go for 10 more minutes and then we'll take a break. Okay, now let's take a look at this. Let's say this is a normal distribution of human beings, and out here on the end we have people that have depression. All right, they have the symptoms of depression. Let's assume, and I think this is a fair assumption, that those people that have extremely severe depression are in the very far end of the distribution. Okay. And there's a lot of research that suggests that extremely severe depression, it may be caused by many things, but it's accompanied by very significant changes in brain functioning. All right. So if we only look at the most severe cases of all and treat them with biological treatments, whether it's medicine or shock therapy or what have you, the results actually are pretty good. And that's what's happened. That's what's happened, what has evolved, over the years. Now, what happens then, though, is good treatments for these extremely severe, maybe inpatients, okay? Well, it works for them. Let's start using it for somewhat milder cases. And sometimes it works, and sometimes it doesn't. Because when you start moving away from the extremely severe, you probably are running into more, these mild to moderate depressions may have a lot more to do with life circumstances, might have to do with their characterological makeup. There are some people that are just kind of chronically depressive, okay, stuff like that. It may not, in fact, be the kind of depression that has a strong underlying neurochemical piece to it. Okay, so what's going to happen then is if you say, okay, let's give all these people a biological treatment, guess what? The results aren't going to look as good, right? Because actually what you're doing is you're using biological approaches on people that their basic biochemistry is probably okay. Now, is everybody with me on this? All right. So the solution to this then is to be able to diagnose those people, not just in those severe, but those people that are in the mild to moderate range that probably have an underlying neurobiological piece to their illness where medication can be helpful. But not just give everybody that feels sad antidepressants. Maybe I'm stating the obvious, but that's a part of the diagnostic part. And in this class what we're going to do is look at medication treatment, but also really look at critical diagnostic issues to help differentiate out which people could benefit from medicines versus those that don't. Okay? First thing, do no harm. First rule of medicine, do no harm.